Yeah, so yeah, we apologize for this technical mishap. I think it was a hacked meeting. So Dr. Saeed will restart presenting.
Okay, all right. So just to recap, we have a 52-year-old gentleman with type 1 diabetes diagnosed at the age of 1 year, complicated by peripheral neuropathy, nephropathy, and retinopathy. Um, he underwent combined kidney pancreatic transplant 3 months prior. He was induced with ATG and maintained on tacrolimus, MMF, and prednisone. This was a CMV seronegative recipient in both the donor and recipient negative transplant, EBV positive. Also an exceptional distribution criteria transplant due to donor bloodstream infection secondary to MRSA, for which the recipient completed 14 days of intravenous vancomycin. 3 months after the transplant, our patient is admitted with disseminated skin rash and fatigue, which has been going on for about 3 weeks. He's afebrile at the time of presentation, but had been intermittently febrile at home. The rash appears quite diffuse, erythematous, papular dominant, involving his entire body, including the palms. There are no bullae or vesicles at the time of the exam. And this is what the rash looks like. With respect to his blood work, his white blood cell count is 6, ANC of 3.5, ALC of 0.1. Hemoglobin is 101, platelet count is 367, serum creatinine is at baseline. ALT and AST are mildly elevated from before. Prior to this, they were in the 50s range. ALK phos is within normal limits. INR was 1, and blood cultures were collected at the time. So I'll go ahead and try to open this poll again, not trying to try to see if I can open the poll.
Huma, would it be possible to show the rash again?
Yes. This is what the rash looks like, and the poll is open now. What are you guys mostly concerned about? Okay, so we have 7 responses so far. All right, so some of the people reported they were concerned about drug reaction. About 33% of those who answered are concerned about disseminated VZV, which is what our initial concern was as well. Some of the people were concerned about drug reaction, and 20% of those who answered mentioned none of the above. Okay, so I'd be curious to see what they think. And what would be your next steps? Let me try to release this one. Right? So we have 10 responses so far, and the prevalent vote is for a skin biopsy, which is very reasonable. So kudos to our extraordinary dermatologist who saw the patient and was quite concerned about this being more of a lichenoid skin rash, and so the patient ended up getting a skin biopsy on the same day, which showed interface lichenoid chronic inflammatory cells with scattered dyskeratotic keratinocytes, overall quite concerning for graft versus host disease. Because of the mild transaminase elevation, the patient also ended up having a liver biopsy, which showed histological analysis of cell dropout, early ductopenia, and all of the changes that were consistent with chronic GVHD. Now, while this workup was undergoing, the patient developed pancytopenia. Mind you, he has already been started on high-dose intravenous acyclovir while this workup is undergoing for concern for VZV and HSV, or disseminated VZV infection. The swab from the VZV, swab for VZV and HSV PCR from the skin lesions was negative. He underwent a bone marrow biopsy after he had developed pancytopenia, which was quite inconclusive. It did show normal cellular marrow, but then he underwent chimerism studies, which showed about 43% donor DNA in the peripheral cells. Digging into his chart, it was noted that at the time of transplant, the recipient ended up receiving a small part of the duodenum from the donor, which was anastomosed with a jejunum. So because of concern for graft versus host disease, he was treated with high-dose prednisone with slow taper over the next 4 months. He generally did well, had counts recovery as well as normalization of his liver chemistries until 14 months after the transplant, when he was admitted with weakness, fatigue, and neutropenia. This hospitalization was unfortunately marred by numerous complications, predominantly related to recurrent bloodstream infections. He was initially presented with MSSA bacteremia that eventually ended up getting Enterobacter, Cloacia complex bloodstream infection, VRE bacteremia, Pseudomonas aeruginosa bacteremia, and ended up getting C. difficile associated colitis. Furthermore, he was also noted to have a large mass in the right hilum. There was a bit of uncertainty around the diagnosis, so he underwent bronchoscopy with BAL culture showing Aspergillus flavus and BAL galactomannan quite high at 6.35. He had a repeat bone marrow biopsy, which now is hypocellular, completely aplastic, and the tiny bit of cells that were present were mostly T cell population. He underwent peripheral blood chimerism studies, which now show 97% donor T cells. He was started on high-dose steroids. There was a discussion around whether to proceed with rabbit ADG versus alemtuzumab. During the course of it all, he was maintained on broad-spectrum antimicrobials, several gram-negative coverage agents at different points in time, piperacillin tazobactam, meropenem, ceftazidime, oral vancomycin for C. difficile associated colitis, and intravenous amphotericin was started when we saw the hilar mass. Unfortunately, before either rabbit ADG or alemtuzumab could be initiated, he clinically worsened, and family conversation was held to discuss goals of care, and they decided to eventually withdraw care. The patient ended up passing away in the hospital. So this brings me back to this really important yet rare syndrome called Blowback syndrome, which is a term oftentimes used mainly in the transplant immunology to describe the counterintuitive phenomena whereby donor-derived immune cells that are transferred with the graft mount an immune attack against the immunosuppressed recipient. It illustrates the bidirectionality of alloimmunity in transplantation, and also challenges the assumption that the donor cells that are transferred at the time of solid organ transplant are always passive. So the objectives of my talk today, by the end of this session, the participants should understand, or would be able to hopefully understand, the immunopathogenesis of solid organ transplant, GVHD, identify risk factors and clinical presentations across different organ types, analyze patterns of infectious complications, evaluate evidence for current treatment strategies as well as prophylaxis, and discuss emerging therapies and research gaps. So graft versus host disease in solid organ transplant occurs in two forms. The more acute or hyperacute form is antibody-mediated, where the antibodies from donor cells with blood type O attack the recipient's RBCs with blood type AB or AB, leading to mild transient hemolytic anemias. These are more common in ABO incompatible transplants and are commonly seen in those cases in liver transplant recipients. Less commonly in kidney transplant recipients, and they're transient and typically resolve spontaneously. This is also called passenger lymphocyte syndrome. The more important and serious one is cellular mediated, which is what we'll talk about today. So this is where donor-derived T cells have a reaction to histoincompatible cells in the recipient's skin, liver, and GI tract, as well as bone marrow. 3 preconditions, which are also known as Billingham's classic criteria, need to be met in order to create a perfect storm for development of GVHD following solid organ transplant. So viable donor immune cells, also called passenger leukocytes, they are typically transferred within the organ and sometimes with perioperative blood products. These include T cells and antigen-presenting cells. Then recipient expresses alloantigens that the donor T cells can see. Recipient is temporarily unable to clear the donor leukocytes because of induction or maintenance immunosuppression and perioperative inflammation. The Lafferty-Cunningham two-signal model is a foundational immunological framework that explains how T cells decide between activation versus tolerance. And I decided to put it here as a small refresher from med school immunology. In signal 1, which is occurring here, the T cell receptor recognizes the peptide presented on the MHC by an antigen-presenting cell. This recognition is necessary but not sufficient for the T cell activation. This process is then followed by step 2, which is the co-stimulation, which is provided by co-stimulatory molecules such as CD80 and CD86 on the APCs, engaging with CD28 on the T cells. If any of these signals occur in the absence of the other, the T cell undergoes apoptosis and functional unresponsiveness. This is the immunological basis of tolerance induction. If both the signals are delivered, full T cell activation takes place, which then leads to proliferation, cytokine production, differentiation into effector cells. In GVHD or even in acute rejection, the inflammatory milieu supplies a signal to overcoming the tolerance mechanisms and leading to T cell proliferation. This slide elaborates the mechanism of development of GVHD following the solid organ transplant. So with the organ implantation, donor T cells and APCs enter the recipient circulation. In liver and small bowel, the inoculum is large and donor immune cells disseminate systemically, which is also called a process called microchimerism. The donor T cells and APCs traffic to secondary lymphoid tissue and bone marrow in the recipient. This lodgement creates a platform for antigen encounter as well as clonal expansion. The T cell activation takes place via the two signal model that we talked about. This leads to clonal expansion of the donor T cells, which secrete IL-2, interferon gamma, TNF alpha. This further amplifies APC activation and tissue inflammation. We also have cytotoxic effector mechanisms, including perforins and granzymes, which cause cytolysis and apoptosis of the recipient epithelial cells. And certain organs such as skin, and bone marrow, and gut, they are more prone to being involved because they have highly immunogenic interfaces, which leads to development of an organ damage. Bone marrow donor, in the bone marrow, the donor T cells also proliferate and take over the hematopoiesis, leading to pancytopenia. Liver involvement is typically less common and is more of a hallmark of solid organ transplant GVHD, specifically in people who have undergone liver transplantation. The timeline is quite rapid. Symptoms typically emerge within the 3 to 8 weeks post-transplant. It's consistent with time needed for activation, expansion, and tissue homing. And the classic triad of rash, diarrhea, and cytopenias predominate, and oftentimes people present with these three symptoms. Fever is quite common. This triad is also what we call as the every ID consultant's nightmare trifecta. This overlaps with infection and drug reactions, which leads to frequent diagnostic delays. With respect to which types of organs are more predisposed to developing the GVHD, small bowel and multivessel visceral transplants are more reported, cumulatively up to 10% in literature, and a lot of the cases were in pediatric population. Liver transplant is also a risk factor for solid organ transplant GVHD. The incidence is up to 2%, and there's really high mortality. With the rest of the organ transplants, the incidence is not that high. It's quite rare, and less than 30 cases are reported in the literature. With respect to organ involvement, again, most people would present with a skin rash, GI tract involvement presenting with diarrhea, as well as cytopenias. Liver involvement typically presents with biochemical hepatitis or cholestasis, although it's quite uncommon in liver transplant GVHD, which is oftentimes a hallmark of GVHD. And lung and respiratory involvement, again, is also quite uncommon compared to GVHD observed after hematopoietic stem cell transplant. Diagnosis remains it's quite challenging because of lack of clear diagnostic criteria. It's typically established through histopathology of the skin or GI tissue. And the histopath will show apoptotic keratinocytes, crypt cell necrosis. Marrow biopsy oftentimes shows aplastic anemia with donor lymphocyte infiltration. Chimerism studies or in sex mismatched transplants, FISH studies may be conducted. And again, differential diagnosis is quite broad, can mimic anything like a skin rash, in viral exanthems, or acute rejection. With respect to infectious complications, they are mainly driven by two synergistic factors. There's profound immunosuppression from the GVHD therapy itself, such as hydrosteroids, ATG, CNIs, as well as biologics, but also the cytopenias and marrow failure that is quite prevalent in solid organ transplant GVHD from donor lymphocyte infiltration leads to development of a lot of opportunistic infections from endogenous pathogens. Infections are primary cause of mortality in more than 80% of the cases were reported in the literature. Among liver transplant GVHD, a series reported 83% developed severe infections leading to mortality, and median survival is around 40 days from GVHD diagnosis. So donor T-cell engraftment leads to marrow infiltration, which leads to pancytopenia and mucosal barrier injury. Hydrosteroids plus minus ATG and CNIs escalate net state of immunosuppression, which results in impaired cellular immunity and phagocyte defects. There's also skin barrier disruption because of the GVHD-related dermatitis and central line dependence, which leads to increased bloodstream infections. Microbiome disruption from the antibiotics, from GI involvement, that leads to enteric translocation of gram-negative pathogens. From infectious complications, bacterial infections are quite predominant. They're the most common cause of death in solid organ transplant GVHD. Typically, the pathogens that are implicated are gram-negative, enteric gram-negative, VRE, specifically in people who have undergone liver transplant. Typically, nosocomial bloodstream infections are also encountered during the episodes of neutropenia. And in one series, C. difficile-associated colitis was found in about 1/3 of the patients. Timing is median time to onset of bacterial infection is around 2 to 4 weeks after the GVHD onset. So they're quite rapid and quite quick to come on. This is a nice case series published in 2022 of assessing the infectious complications in liver transplant GVHD. And as you can see here, most of the patients who had GVHD ended up developing some form of bacteremia, predominantly from endogenous pathogens. Viral infections are also quite common. CMV reactivation takes place frequently. Risk of lymphoproliferative diseases through EBV reactivation is theoretical, although less reported due to cytopenias. Again, HHV6 and parvovirus B19 infections can also happen, although they may mimic or exacerbate GVHD pathology, so they compound the diagnostic challenge. Invasive fungal infections, despite prophylaxis, are quite common as well, as we saw in our patient's case. In one case series published out of Iowa in 2017, reported up to 1/3 of the patients had breakthrough candidemia despite prophylaxis, and more than 1/3 of the patients had invasive pulmonary aspergillosis. PJP prophylaxis is typically started when people are diagnosed with solid organ transplant GVHD. Hence, incidence of PJP with prophylaxis is quite low, but breakthrough is possible if nebulized pentamidine is utilized in place of the usual trimethoprim sulfamethoxazole. Treatment for GVHD intensify. There are two schools of thoughts. The traditional approach is to intensify the immunosuppression with high-dose steroids plus minus higher CNI doses. This has quite poor survival and it does not necessarily, the high-dose steroids are not necessarily, it's a blunt instrument in that they're not the definitive treatment, and a second-line or a more definitive therapy should be considered in these people. The other school of thought is to actually reduce or withdraw immunosuppression to let the host immunity clear donor passenger lymphocytes. This has been proposed in the liver transplant case series and is now supported by newer intestinal transplant data. In a pediatric small intestinal transplant cohort, reduction in immunosuppression was significant. It led to significant improvement in the overall survival versus intensification of the immunosuppressive therapy. Again, the first-line treatment is high-dose steroids, but response with high-dose steroids is oftentimes incomplete, and so one should plan for a second, more definitive agent, such as rapid ATG. In steroid refractory cases, there are many drugs that have been studied on a more sporadic case series level. We have IL-2 receptor blockade, better survival outcome compared to CNI uptitration in liver transplant GVHD. We also have anti-TNF alpha inhibitors such as infliximab. Again, small liver transplant case series and case reports show that it lowers the mortality versus historical regimens, and typically has to be considered in people with GI predominant disease. The CD2 blockade, there's also a small signal of benefit in small liver transplant series. The availability varies in different centers, though. And then one of the newer agents, ruxolitinib, there's growing solid organ transplant experience with encouraging responses. It has, in fact, been approved for, FDA approved for steroid refractory GVHD in hematopoietic stem cell transplant. Some other mention-worthy names are abatacept. Its use was reported in a single liver transplant case report. Usually, the experts recommend considering this when T-cell co-stimulation blockade is attractive or other agents are contraindicated. Again, it would not necessarily be the first-line therapy. ATG is frequently used in combination with high-dose steroids, and one needs to be monitored for profound lymphopenia and infectious complications. Extracorporeal photopheresis, it's helpful especially for skin-predominant diseases or as steroid-sparing agent. It has been used in intestinal transplant series, but again, not very significant results. And anecdotally, rituximab or OKT3 antibodies, IVIG, those have been used as well, but the data is quite sparse and mixed, and they're typically reserved for select scenarios or in combination protocols. Other treatments that have been looked into are mesenchymal cell transplants. They have been attempted in, I believe, one or two case reports from intestinal transplant GVHD and failed in both cases. Irradiation of the liver in liver transplant GVHD has been done a couple of times. Once during my fellowship, there was a patient that had similar presentation, ended up getting irradiation of the liver, which led to some clinical improvement, at least for the short term. Other considerations include transfusion and infection control nuances, so irradiated blood products should be used. Infection prophylaxis should be tailored to neutropenia. Levofloxacin is oftentimes recommended if a patient does not have an active bloodstream infection. Posaconazole is preferred, although fluconazole remains standard. But extended azole prophylaxis is typically recommended in endemic areas with higher prevalence of invasive mold infections. Viral prophylaxis is equally important. Valganciclovir either for CMV, specifically people receive ATG, plus minus acyclovir if valganciclovir is not being given, and PJP prophylaxis. Early broad-spectrum empirical antimicrobials for febrile neutropenia are important. If there is hemodynamic decompensation, always consider VRE or MDR gram-negative, and antimicrobials should be escalated to cover these. And close CMV and EBV monitoring is recommended with PCR assays. Despite prophylaxis, though, the breakthrough infections are quite common and lead to really high mortality, up to 80% in liver GVHD, and around 30% reported in intestinal GVHD. Median survival after GVHD diagnosis is around 40 days, and death usually results from sepsis and multi-organ failure. For survivors, they typically remain on prolonged immunosuppression. There's risk of chronic infections as well as malignancy. I would also like to point out some research gaps and future directions. So obviously, it's a rare phenomena, but lack of a standardized diagnostic criteria as well as no consensus treatment guidelines make management a bit more complicated and nuanced. They're very center protocol driven. There is need for biomarkers of early GVHD, studying ST2, Reg3 alphas that are already validated in hematopoietic stem cell transplants. Donor-derived cell-free DNA is, again, an interesting area of research that's still evolving, and perhaps utilizing this marker to predict or to use in combination with other early GVHD markers may result in quicker diagnostics. Targeted immunotherapy with JAK inhibitors and cytokine blockade is an area that's currently being studied. Prospective studies on antimicrobial prophylaxis strategies are needed, and collaborative registries for solid organ transplant GVHD are needed as well. So to summarize, solid organ transplant solid organ transplant GVHD is a rare but devastating complication. Infectious complications are the leading cause of death, driven by two factors: profound immunosuppression and bone marrow failure. It requires early suspicion, biopsy, and chimerism confirmation. Treatments typically high-dose steroids plus adjuncts, but infections limit survival and administration of these agents, as was seen in our patient's case. Prophylaxis is essential, but often is insufficient, and there is need for individualized aggressive monitoring. So to summarize, high-dose steroids are a blunt instrument, and perhaps targeted immunotherapies might be our best hope. Until then, the key lesson is think of it, biopsy it, and prophylax like your career depends on it. And with this, I will open the floor for any questions and comments.
There's a question, Sasan.
Oh, thank you so much for this excellent presentation. I don't know I have no background information about this pattern of GVHD in SOTs. We had an increasing trend of chimerism and homing, which is relatively different from allo patients when they get GVHD. Is it something that we need to consider in GVHD in SOTs or no?
So I think that from my limited study, I think the diagnosis is quite challenging because chimerism has been reported I think in a study that was published as early as 1992 by, I forget their name, Stars or something, that reported chimerism in different, or microchimerism in different organs. And so when to take that into consideration, when to perform it blindly without it fitting in the correct clinical context, I think that remains a challenge. Perhaps those should be considered. Again, chimerism studies are important if it fits in the clinical picture, but they shouldn't be used solely to establish the diagnosis, which again underscores the importance of not having clear-cut diagnostic criteria.
Right. Thank you. So because your case had increasing trend of chimerism, and I think probably homing as well, because the samples, if I remember correctly, was from
Right.
bone marrow. And did your patient receive ruxolitinib as well, or no?
No, they didn't. They were initially when they had presented, they had pancytopenia, skin rash, not sure about diarrhea, but certainly liver involvement, biopsy-proven liver involvement, biopsy-proven bone marrow, biopsy-proven, dermal involvement. And so they were treated with high-dose steroids with slow taper. They weren't treated with anything else. They did have a quick recovery in their white blood cell count and normalization of their biochemical markers, which suggested clinical improvement. Having said that, this was also around almost a year prior to they had presented to the hospital with florid GVHD.
Thank you.
Thanks, Huma.
Rothstein has the question.
Thanks, Huma. That was really interesting. Just to follow up on Sasan's question, you didn't come across in your literature search any literature that points towards a role for chimerism studies to predict GVHD, right?
No, it's just, again, it's a nuance. You won't really use that test because microchimerism has been reported even in people with immune tolerance. And so it would be difficult. Maybe something's being done within the research realm, but not to be used as a predictive criteria.
Yeah, it would be interesting to do that in maybe the small bowel population and see how many people actually develop chimerism without manifesting at all. And then there would probably be more people with positive chimerism studies and not really be symptomatic, but who knows? Coleman Rothstein has a question.
Thank you very much for your presentation. Did you run across any data on the use of ruxolitinib with photopheresis? Because in marrow transplants now, they're using combination therapy.
Yeah, no, so with the combination therapy, again, the report is limited with just how rare the disease is in solid organ transplant. There have been case reports that have looked into ruxolitinib, and there have been case reports that have looked into ECP. To my knowledge, not in combination with each other, but again, I could be wrong.
No, there are some data from marrow transplants that the combination works better. Either.
You're talking about marrow transplant or ECP?
No, marrow transplants.
Okay, yeah.
Looking at both photopheresis with ruxolitinib, the combination together.
Correct. Yeah, not that I saw, at least in my limited search in the solid organ transplant GVHD.
Okay. And just taking off from what Sarah said, it would be useful, particularly with pancreas transplants where part of the duodenum is taken and there can be lymphoid tissue, or with small bowel screening. I think the screening for chimerism, I think that would be useful process and be an interesting thing to see. What percentage have it and how high the chimerism is?
Yeah. And again, I think ultimately, I mean, we know that microchimerism has been demonstrated even in people that do not develop GVHD. So you're right, what percentage has it and up to what extent? And are there thresholds where we would worry about solid organ transplant GVHD? I think that's an emerging area of research interest and does require a lot of budget, but certainly worth looking into.
Yeah, the trouble is to fund research like this when it's such a rare complication, then the question will come, how many people do you need to screen to pick up a case? And then we don't even know.
Right.
Yeah.
And I think Anthony has a question as well.
Huma, that was an incredible presentation. One question I had was, in this patient who had recurrent infection, and particularly as this is a kidney pancreas, was there a point where you considered using that strategy of withdrawal or reduction immunosuppression?
There was a time when I think the patient was not on anything. Again, that didn't really, because the clinical course with infectious complications progressed so rapidly, we didn't have enough time to see if the strategy of withdrawing all immunosuppression, because there was a time when he wasn't on anything, would lead to any clinical benefit. Because the infectious complications with invasive pulmonary aspergillosis, numerous bloodstream infections, C. difficile associated colitis, that led to quite rapid clinical deterioration and decline. If we weren't dealing with these numerous infectious complications, perhaps it would have been helpful to see if there was improvement, as has been reported in some, like I think some case series of intestinal GVHD where they've withdrawn immunosuppression and that has led to some clinical recovery.
Okay. Any other questions? Okay, and you have your email up there in case anybody thought of any other questions. Please make sure to fill the survey. We need this to maintain our accreditation. Thanks so much, Huma, for presenting. This was really excellent. And we'll see you all in December. Stay well.
Thank you, everybody.
Thank
Take
you.
care.